Hello and welcome back to Don't Miss a Beat. Today we are continuing a conversation from a few months ago about hemodynamics, and what we are focusing on right now are going to be the waveforms. So we're going to walk through each of the chambers. Good news is, even though there are 6 areas, 2 of them are the same, so you really only have to learn 3 waveforms and kind of walk through what you're looking at when you're walking through each chamber of the heart and what all the waveforms are. Now, if you have the Cath Lab Visual Orientation Manual, the newer edition, this kind of starts on page 117 where we talk about the atrial waveforms, and you'll see it's broken down atrial, ventricular, and arterial, and then it talks about each of the phases and what happens. So this lecture really coincides with that really well, and it goes into a little more detail, but we're going to work on some application on looking at real waveforms. So let's get into it. Basic Waveforms 2.0, because this is a re-recording and a little bit of an update from some audio issues that I had the first time I ever started my YouTube channel. So to start is atrial. Now remember, I said one waveform, so one kind of drawing for 2 chambers, because you have 2 atria, right? You have the left atrium, that's what LA stands for, and the right atrium, that's what the RA stands for. Now, the left atrial pressure you might hear as pulmonary wedge pressure, and just what that means is how you're achieving that. Either you're achieving it from a right heart cath and you're wedging the swan into position to represent the left atrial pressure, or you are transeptal through the intraatrial septum and you're directly reading a pressure and transducing a pressure from the left atrium. Both are possible. Both waveforms are going to look pretty much the same. And then you have the right atrial pressure that you achieve from the Swan-Ganz catheter. Now the values you're looking at, I just wrote the normals. Remember, there's ranges for all of these if you're not familiar with how I teach normals, but when you're first learning, you want to be able to write a list, so kind of pick one number that's in that range so you can start to memorize it that way. You see there's 3, 1, 2, and 3. The first one for LA, 10, 13, and 8. So what do those actually mean is important, because that coincides with if you see the names on the waveform. So A is the first number, so that'd be 10 and 6. V is the second number, that's 13 and 5. And M is the last one, 8 and 3, which we will talk about. Because if you notice on this waveform, you have A, C, X, V, and Y. There's definitely no M. That's because M stands for the mean, which you do have to calculate. But other than that, A you can get from the peak, one peak, and V you can get from another one. And deciding A between V, which we will do an example of, you have to have this, a rhythm strip of some kind, so that you can see the QRS complex, because the A wave is between the P and the T wave, so I kind of call that PAT. That's how I remember. And then the next one is the V, which is between the T and the next P wave. See, when you get a nice drawing like this, you see it, but in real life you don't really see the C wave, because as you'll see in a minute, there's a lot going on with the atrial waveform. You can get a lot of respiratory variance, and it can be really difficult to actually tell the difference between the A and the C, or the C and the V. So where is there an M? Well, there isn't. You would have to calculate this. So the formula for atrial mean is not the same as the mean pressures for the arterial waveforms that we'll talk about later. This formula is A plus X over 2. Now remember, I told you this looks really different in real life, so we'll talk about it, but X would be the bottom of the X descent. So you see you have the bottom of this X descent. This trough right here is what you would look at on the scale to measure. So let's just do this as a very quick example. Obviously this is not on a scale, but let's just put it on scale so you know. Let's say this is 0. I'm just going to put 10 here so it's easier, and 15. So your A wave you would measure as what? 15. So if we were drawing, let's say this is pulmonary wedge pressure, we were writing our pulmonary wedge pressure is equal to A, which is 15, over the next one, which is V. And your V wave is about here, so between 10 and 15, we could say this is 12, this is 13. And then the mean we have to calculate. So we would take the A being 15 plus the bottom of the X descent, which is about, well, if I really drew a straight line, we're just going to call it 10 to make it easy, divided by 2. So that would be what? 25 over 2. Okay, and 25 divided by 2 is 12.5. Now, all pressures are in measures in millimeters of mercury. That's mmHg, including the 15, 13, and 12.5. So this is what your pulmonary wedge pressure fully is reported as, 15, 13, and 12.5 as the mean. Okay, so let's look at a real example. Now, respiratory variance you can get with any pressure you have, especially if your patient has sleep apnea or really bad COPD. Remember, sometimes we're sedating these patients, which can exacerbate some of those issues. So if you see up here, this one looks nothing like this one. You do have the surface EKG to go off of, so we can talk about timing, but you see all these peaks and troughs. How do you know where to measure? Because the pressure down here will be very different from the pressure up here. Well, that's where, if you've ever heard it before, we want to measure at the end expiration. Okay, end expiration before their next inspiration. So if you see on here the peaks, troughs, right? The end of expiration would be like here before it starts to plateau back down. And that is where you would try to identify your A, V, and measure your mean. The other thing is you'll see a lot of examples, sometimes that are all over the place. You'll have an A measured here, a V measured here. What I want you to try to do when you're first learning is measure everything during a single cardiac cycle. Okay, there's a lot that can go on between points A and point B. And of course, some things are average, like FFR and IFR. When you're used to seeing that, it does take a whole screen of measurements and reports out that average. But for this one, you're doing it by hand. You're going, especially for the boards exam, you're going to want to pick one single cardiac cycle to try to identify everything in one moment in time. So we can try to do that here. Now the scale, let's work that out. Okay, so I drew out this scale for you. The next thing we need to do is work on our where is end expiration. They're expiring, inspire, expire, inspire. So let's just choose this one. This is kind of the end before it goes back down. So I want to measure in this area. So let's use this QRS complex. So this is P, R, and T, and the next P. And I'm just going to draw some lines down. So let's take this as the P wave, and this is the T wave. Actually, let's just put it between, P and T. So this big one here is probably the A wave, and then remember between the T and next P is the V. So this one is probably the V wave, and in between is the X. So we'll call this the bottom of the X descent. So if I move this over, put this in a different color for you, let's do a blue. The A wave comes out at about 32. The V wave comes out about 28. And the bottom of the X descent, could move that down a little bit. It's a little above 20. Fine, 21. All right, so the A was what? All right, it says pulmonary wedge pressure. The A is 32. The V is 28. And then the mean we have to calculate, right? We're going to use A plus X over 2. So A was 32 plus the bottom of the X descent, we're saying is 21 over 2. So that's 53 divided by 2 is, not doing that in my head, 17.3. And remember, millimeters of mercury. So that is your reported pulmonary capillary wedge pressure. Next, we have ventricular pressures. Same idea, one waveform, two chambers. So you have the left ventricle and the right ventricle. Normal LV pressure, remember there's ranges for all of this, 120/09, RV 25/915. But what do those numbers mean? So the first one is systole, then you have BDP, which is beginning diastolic pressure, EDP, which is end diastolic pressure, and you definitely have more phases in this waveform because you have atrial contraction, isovolumetric contraction, and then you have ejection and isovolumetric relaxation, and then you have that filling phase. So what we are looking at are not these exact phases, but moments before or after some of these phases occur. So systole might be the easiest, right? It's the systolic peak here and or here. Beginning of diastole and end of diastole is actually in the middle here. This is diastole, right? This is systole, this is diastole. So the beginning of diastole is here, and then the end of diastole is here, and then systole starts. So what you're going to do, EDP is really what has a landmark. You line it up with the R wave on, again, the surface EKG. So if you're noticing a trend, you kind of need that for all of these waveforms. You'd find the peak of the R wave, bring it down. I probably didn't line this up super fantastic, but we'll do some real examples in a minute also. And wherever it lines up and intersects with the left ventricular waveform is EDP. So if you noticed, it intersects right here, whereas some people make the mistake of measuring EDP down here, but actually you need to measure it wherever the R wave lines up, especially for the board exam. Please don't make that mistake. So remember, EDP is wherever the R lines up to the LV waveform, not necessarily right where that begins. And then beginning diastolic pressure is here. Now, I know in order of this waveform, it's kind of backwards because you measure end first and then you have beginning at the end of the waveform. But if you had two back to back, it wouldn't make sense. You'd go, okay, this is systole, this is systole, this is diastole. So beginning diastolic pressure is here, and of course, end diastolic pressure is over here. So I would just estimate beginning in that area. Okay, so let's do an example. Here you actually have two waveforms. Do you know what they are? Now you're assuming it's AO and LV. I know it's labeled up here, but because of the scale, it's on a scale of 200. That's very unfortunate if the patient had a right ventricular pressure of 200. Not that I've never seen it before, but for practice purposes, let's say this is LV and this one over here is AO pressure, but we are just going to ignore the AO pressure for now and measure left ventricular pressure. We have our surface EKG, which is great because we need that. Now, there's not too much variance here. There's a little bit, but nothing really to write home about. So I just really want to choose one that doesn't have any of these markers on it. So let's just go with this one right here. So I would say LV systolic pressure. I'm going to bring that over to scale. This one is beginning diastolic pressure. How dare I put my logo in the way? But we know down here is 0. So I'm going to say that's 10. I'm going to say this is right on 180. And then remember, EDP we measure by bringing down a line from the R on the QRS complex, and where it intersects, so right here, is going to be our end diastolic pressure, which that's probably more 10 than the other one. So I'll call this one 10 and I'll call this one 5. So then when you report it out, you'd be writing that the LV pressure is 180 for systolic. Now what is beginning diastolic pressure? 5. And then EDP you measured at 10, and of course those are all in millimeters of mercury. Now, why do they make me zoom in? When you click the EDP hotkey button when you're monitoring, your scale changes. So whereas over here you see the full LV waveform, you see the peak, full peak and trough, and then you see the surface EKG, there's a nice space between here. That's because it's on a scale of 200. If my systolic is 180, then yeah, I'm definitely going to be able to see the full LV waveform here. If you have a patient who's very hypertensive or has left ventricular hypertrophy or HOCM and you're getting LV pressures in the 210s, 220s, you're going to have to increase the scale a little bit so you can see the full LV waveform. Now, over here, remember when you click that hotkey, it's automatically going to go to a 50 scale. So remember, my LV pressure was about 200 systolic. So it's not that it is not measuring systole, it's just way off of the screen. Okay, so the systolic peaks are all the way up here, really more tenfold, and that's why you can't see it. You could bring the scale all the way down. The reason that it goes to this is because EDP, remember, is in the teens, right? The teens and 20s. So before, when you had me make a line and bring down the line of the R wave, this is just to make it a little easier because it keeps the surface EKGs there so that you can measure it easier with your eyeball, just making sure that it's measuring EDP at an appropriate place. You'll notice it does mark out the EDPs for you. It's saying, hey, I'm measuring here, but it doesn't always go in the correct spot, which is why this moment is important for you to look at the QRS complex, kind of have an idea of what EDP is, and verify, yes, it is measuring at the correct place, because we diagnose a lot off of EDP. It tells us a lot about left ventricular function. So let's say it was marking EDP all the way up here, and it was marking off of the S wave instead. Well, that's going to read me an EDP in the 40s. That's telling me my patient has really end-stage heart failure and is really struggling with compliance. But in reality, their EDP is all the way down here, just the computer sometimes measures incorrectly, and you're smarter than the computer. So it's always good to double check when the screen comes up. But also, if you forgot to snap a full LV pressure, don't worry, because this screen actually did capture the measurement for you and the full waveform for you. You just aren't actually seeing it on the screen. And last but not least, we have the arterial waveform. This one can be a bit of a misnomer because you have both arterial and venous system, but remember the pulmonary artery is called an artery, or it has artery in the name. So you have AO, which is 120, 80, 93 in the arterial system, and PA, which is 25, 9, 15 in the venous system. So what those numbers stand for are systole, systolic pressure, diastolic pressure, and the mean. This mean is more the mean you know because you're used to probably calculating MAP, mean arterial pressure, and for the PA, that's just MPAP, mean pulmonary artery pressure. Exact same formula, you just are pulling the numbers from two different places. And this is the waveform, which you should be also used to because it's your AO waveform or your A-line waveform, because wherever you are in the body, the amplitude might be a little different, but the components are the same. You should have a systolic pressure, you should have a diastolic trough, it should be a little asymmetric, and then not always, but the closer you are to the heart, you'll see that dicrotic notch from the valves closing, from the semilunar valves closing, which is your aortic valve and your pulmonic valve, which makes sense that it would show really well on these waveforms. So again, where is there an M? Now remember, the other one was during the atrial pressures, right? AV mean. So you need to know these means are not the same. So when I'm writing my pressures, my little cheat sheet, I write AVM for this one, but whenever I write my PA pressures, I do usually systole, diastole, MPAP for the PA and systole, diastole, MAP, so that I remember these are different from the atrial mean with the AV and mean. So the formula for this is systolic pressure plus 2 times the diastolic pressure over 3. Now, how you do this in order, you do this part first, 2 times the diastolic pressure, add it to the systolic pressure, and then divide the whole thing by 3, and we will do an example. So let's just do it here and say my pretend scale again. I'm just going to use this at 25 because it's easy, and we're just going to call this 10 because that's what we're doing. So let me say my systolic pressure for PA was 25, my diastolic pressure was 10. What is my MPAP? It is 25 plus 2 times 10, which is 20 over 3. So that's 25 plus 20 over 3, which is 45 divided by 3, which is, I don't do mental math, so on the computer, 15 millimeters of mercury. So you would report it as 25, 10, 15. Okay, so I hope that helps as an example. And then we'll look at a real waveform in a moment. This waveform should look familiar because that's an LV waveform, right? But this time we're going to ignore the LV and take a look at the AO waveform. Most of these systolic peaks are the same. We'll just make it easy and use the one closest to the scale. So we need our systolic pressure and our diastolic pressure, which is down here. Really, it should be this one, I guess, but here, because I like to use everything off the same cardiac cycle. All right, so AO, systolic is about 95. Diastolic is about 46, not really 50. And then what was our MAP, our mean arterial pressure formula? Systolic pressure plus 2 times the diastolic pressure over 3. So I'm going to take 95 plus 2 times 46 over 3. No, these should be equal signs. I know I'm not a math major. So that is 95 plus 92 over 3, which is 187 divided by 3, which is 62.33333. So we'll say 62.3 millimeters of mercury for your MAP, your mean arterial pressure. All right, I hope that helps. I'm walking through the 3 different waveforms. Up next, we're going to talk about gradients because you guys ask me about those formulas all the time, and we will definitely walk through those. But if you didn't know, we actually now have a platform for EP if you work in a hybrid lab, or if you just work in a dedicated EP lab and came across this video. Make sure you engage with us on Instagram and Facebook at Don't Miss the Hiss. Yes, the hiss is a component of your electrical conduction, but also it's a common electrogram that the EP lab looks at. So you have someone who is an expert in EP with 10 years of experience. That is not me. So she does all the daily quizzes, will answer any questions you have in the DMs, and I am learning right next to her as she's teaching you, as she's teaching me, and I translate that into the fun visual posts that you are used to. And we will have a book coming out for an EP orientation manual with her and 2 other people on the team, bringing you some awesome content for the EP lab. Thank you so much. Make sure you like and subscribe this video, and look forward to more in the future.